Hi, my name is Matthew Stryker. I'm a clinical pharmacist at Albany Medical Center's Division of Community Endocrinology, an assistant professor at Albany College of Pharmacy and Health Sciences, and also a stakeholder in the Doctor-Patient Rights Project.
Hi, I'm Dr. Kim Birtcher. I'm a clinical professor at University of Houston College of Pharmacy and a clinical pharmacist at Kelsey-Seybold Clinic. I work in the cardiology department and I run a lipid clinic. Well, Matthew and I are here today. We're going to talk a little bit about the prior authorization process, some of the things we've experienced, and then maybe share some pearls as far as how you might want to make the process easier for you. I'll let you start.
Sounds good. So a little bit of background, I do help facilitate a lipid clinic at our practice, and probably my main focus of that clinic is getting patients on PCSK9 inhibitor therapy, kind of soup to nuts, so approval to teaching the patient. And there's been a lot of polarizing examples that have really come to fruition recently for patients that are clearly indicated for therapy based on the label. However, we have the appropriate patient, but then from managed care standpoint, not the approvable patient, again, based on their perspective. And one that was really shocking for myself and the provider was a patient who clearly indicated for therapy, top dose statin therapy, high risk patient with carotid plaque, diabetes, fortunately no hard cardiovascular events, so MI, stroke, etc. And this individual, we appealed to insurance for coverage. We were denied, unfortunately, not surprising, right? And thereafter, we did an external appeal, which you can often do, so a third-party, unbiased agency kind of looking at both perspectives and should the patient be approved or not. We were denied again, and I think, persistence is the name of the game here. So we went, this was a Medicare patient. You can go to what's called an administrative law judge, and essentially the third out of 5 rungs on the ladder, if you will, to get a medication approved. And the provider was telling me that this was essentially a peer-to-peer, but again with an administrative law judge with a law background. And this individual had been reviewing our patient's case and was seeking clarification from the provider. But it was interesting because his workup of the patient, the law judge that is, was, I was looking on WebMD and Wikipedia. Can you explain to me what hypercholesterolemia is? So when the provider was discussing that with me, I was pretty shocked to hear that this individual who has essentially the final say in whether or not this medication is approved for the patient at this level really didn't have any relevant medical background or training was pretty astounding to me. So fortunately we did get that one approved, but those type of examples are not unheard of or uncommon.
That's so unfortunate because it sounded like your patient needed the medication and it really would have made a difference. How was the patient in the process? Did they get discouraged or?
This patient, fortunately, was a trooper. She was on board with therapy, so she understood that it could be a timely process. And I think that's one thing that patients appreciate is, in at least my experience, I'm sure yours as well, from the get-go, setting up realistic expectations as far as the timeline goes, because this is it's not just submit the paperwork and get the approval. It's submit the paperwork and then we'll see, kind of.
Right. I've had similar experiences, and I work with students in the clinic, and one of the things about having students available, they have time available, and
Right.
A lot of times we come up with ideas on how they can learn and things like that. Well, I've had such poor experiences with some of the insurance companies in getting the PCSK9 inhibitors in particular approved. I actually have my students, when we want to write a prescription for a patient, I have them call the insurance company and find out which agent is on the formulary.
That's good.
I also try and find out which specialty pharmacy we have to use if it's designated.
Mm-hmm.
And then I also try and find out what copay the patient's going to have to pay, because a lot of times the patients aren't able to afford the copays, that they're having to pay with the insurance companies. It was very interesting. Last week, one of my students called an insurance company and was actually told by the the representative that specialty meds were no longer covered.
Wow.
So it was like, oh my goodness, this was like the second time it had happened to me where I found out, a patient who clearly needed the medication couldn't even get it from their insurance plan because specialty meds weren't covered. Had you run across that at all?
Not related to PCSK9 inhibitors, but in New York State where I'm from, I have seen that with weight loss medications. So I work in an endocrinology practice. We do weight management, and sometimes, unfortunately, weight loss medications are completely excluded. So similar scenario, but now with PCSK9 inhibitors. But what are you left to do in those situations for patients? It's challenging.
Right. I don't know, if I had to give someone some ideas on things to make the process better, I would say definitely good documentation
Absolutely.
is essential.
Yes.
I know in our practice sometimes some of the clinicians think their documentation is good, but when you start looking for the background on why they said a patient was statin intolerant, or what happened when the LFTs bumped, that sort of thing.
Yep.
The documentation's not in a place where you can find it. We've had great luck using the snapshot with our EMR system, where on the problem list we can add some text to
nice.
further explain, why we have said like statin intolerance, for instance. So we can give dates, what doses the patient took, what happened when they were on those medications, and that's definitely helped minimize the amount of paperwork I've had to send in with the prior auths.
I would definitely say and echo exactly what you suggested, in that documentation is the name of the game, and especially with statin intolerances, because a lot of patients coming to us, and sometimes the more challenging patients are going to be your statin intolerant patients, to get on therapy. And one other tip and trick I've kind of utilized as well, in addition to navigating the EMR, is sometimes when I have to call the pharmacy to get the insurance information, I'm asking the pharmacy, depending on how far back their records go, can you tell me what statins the patients filled with you previously? So that way we're getting dose, route, frequency as well. So
that's a great idea.
We're asking in the allergies too, because sometimes in the allergies or intolerances, they're documented there as well. But yeah, documentation is key for sure.
We've been using the allergy piece as well.
Yep.
So instead of saying statin intolerant or just listing the name of the medication that the patient had trouble with, we've been trying to list the dose that they took.
That's great.
If they took it daily, if they took it intermittently, and then what the reaction was. And the thing about the prior auths that I've found is you do them, but you have to do them again at some point.
Yep.
So if you do provide the documentation well the first time, a year from now, when you have to do this whole process again, it's a whole lot easier to
Very
find.
much so. Absolutely agreeing. I have noticed the reauthorization process is more streamlined, but absolutely, if you have your ducks in a row, it goes back to the idiom, stitch in time saves 9, so invest the time up front and it'll be a lot more easy going forward.
One thing I've found to be a bit tricky, and maybe you've worked through this,
Sure.
I know on the reauthorization process, it's very important that the patient have a LDL value within the last 30 days. And I've had a little bit of trouble trying to figure out exactly when I should tell the patient to go for labs, because I need to find out, when are they going to run out of the medication? When are we going to have to fill out the prior authorization? Have you overcome that barrier?
So in New York, I'd say, it's going to vary plan to plan. Our window's a little bit more generous. It's typically 90 days, so it's not the more strict 30 days. But that being said, I think if you could just demonstrate that the patient's been on therapy and consistently the LDLs have been dropped precipitously since the starting the medication, I think that should be a testament. And why do we have to bring the patients in just for labs to show that it's working when they may have come back, let's say, shortly outside the window? But if you're trying to save yourself a headache, then definitely keep the dates in mind for sure, in terms of getting access and reapprovals more efficiently and effectively.
That's great. You have any other wisdom you want to share as we start to wrap up?
I just think, cost is always a consideration too. So access is one piece of it, cost is another. So a lot of patients, we do all the heavy lifting for them. And then especially for the Medicare patients, how do we get those individuals on therapy? And unfortunately, they don't qualify for the coupons, which, $5 copay is great, but federally funded programs, et cetera, don't qualify. So some tips I have for that are the Safety Net Foundation for Repatha via Amgen, and then the PASS program with Praluent through Regeneron and Sanofi. And what's nice about those programs compared to other industry-sponsored programs is that the thresholds for income are very generous. So for example, frequently I'll ask an individual who can't afford the medication, how many people are in your household, and typically it's 2, and is your income at or below around 80,000, and that's a pretty generous threshold for older adults that may not be working. So I'd say those patient assistance programs via the manufacturer, but also independent ones as well. Do you have any similar stories?
I agree with you 100%. Those programs are wonderful, and they've definitely given people access to the medications that they wouldn't have been able to get to otherwise.
And it's free too.
Exactly. All the better.
Right.
I don't see the prior authorization process going away, but I would like to emphasize again the good documentation.
Absolutely.
And then keep it, because you're going to have to go through the process again. Know what the rules are, for the insurance company you're dealing with. You said 90 days. I would love that if we had that in Texas. Right now we're still dealing with a lab within the 30 days. And then use the resources that are available through the patient assistance programs.
Absolutely.
All right.
All right. Thank you very much.
Yeah, it's great talking to you.
You too.